Good morning, and welcome to the Interact Quality Improvement Program Version 3 Advanced Care Planning webinar, the second in a series of Interact webinars. Your host, Dinah Bones, will now begin.
Thank you. Good morning and welcome to today's webinar. We are pleased that everyone was able to join us for the second Interact Quality Improvement Program Version 3.0 webinar. Healthcare Quality Strategies and the Healthcare Association of New Jersey are proud to support NJ Lane as part of Advancing Excellence campaign. Today's speakers include Loretta Case, the Director of Quality Improvement and Clinical Services at the Healthcare Association of New Jersey, and Janet Note, a Quality Improvement Specialist at HQSI. Loretta and Janet were participants at the first Interact Institute held at the Florida Atlantic University earlier this year. Today, they will be sharing best practices of the Interact program in an effort to support quality improvements and prevent unnecessary hospitalizations through the use of advanced care planning. Before we begin the webinar, I would like to review some housekeeping items and make a few announcements. First, I hope that you have been able to download the materials before the webinar. However, if you did not get a chance to get the materials, you may download them by going back to qualitynet.webex.com. You can follow the instructions as listed in the WebEx reminder email sent out yesterday to all participants. We will have a question and answer session following the presentation. We encourage you to use the chat feature to submit comments and questions during the presentation. Please be sure to submit your chat submissions to all participants. Your chat postings will be addressed and answered during the question and answer portion of this webinar. Please note that your phone lines have been muted. After the presentation, the operator will open the lines and you will be able to ask your questions using the phone. We also ask that you please stay on the line after the presentation. The operator will ask polling questions to obtain your feedback about this webinar, so please stay with us until polling concludes. Finally, this webinar will be recorded. We will make the recording available to you along with presentation materials after the webinar, and they will be posted on HQSI.org. Next slide, please. Today's webinar will feature an overview of the advanced care planning tools of the Interact program. We invite you to join us for the June 26th webinar on quality improvement tools. And if you missed the first webinar on communication tools, we invite you to visit the HQSI website to view the recording and the materials. Next slide, please. I would like to briefly note today's objectives. We will be discussing the Interact program's advanced care planning tools, reviewing goals of care, noting National Healthcare Decisions Day, and providing resources. And we challenge you to educate your staff, identify champions, address barriers, and have the conversation. Next slide, please. I now would like to share some remarks from Dr. David Barilli, who will speak about the importance of understanding your patient's goals of care. Dr. Barilli is the Medical Director of Princeton Healthcare System's Palliative Care and Hospice Program and the Executive Director of New Jersey Goals of Care.
My name is Dr. I'm the founder of New Jersey Goals of Care is a nonprofit foundation started in 2009 that focuses on improving healthcare decisions for all New Jersey seniors. We are making efforts to ensure that all treatment decisions are made based on patient-specific goals, whether they be full therapeutic efforts to achieve a goal such as living independently or making it to a family event, or palliative efforts that focus on comfort. Because as people age, their personal goals may change, we believe the medical approach should also change to better match the patient's goals. We believe that a one-size-fits-all model does not apply to seniors or others as they enter their final years of life. This personalized approach is particularly important for those seniors living in New Jersey. During the last 2 years of life, New Jersey seniors can expect to spend more days in the hospital, more days in the ICU, and see more specialists than in any other state. More Medicare dollars are spent in New Jersey during the seniors' last 2 years of life than in any other state. Despite this greater intensity of medical services, most seniors are not pleased with the quality of these services. We've been working hard to alert everyone to what this is, a public health crisis for all New Jersey senior citizens. We know that we can make better healthcare decisions when we organize those decisions around each patient's personal goals. And we've been especially focused on helping hospitals and nursing facilities to improve medical decision-making, offering them tools such as the New Jersey Post Form, tools that help professionals make decisions based on each patient's personal goals. We are also developing curricula that medical schools and training programs may use to better educate young doctors and other professionals on topics such as how to make the proper diagnosis in the frail elderly patient, how to estimate prognosis in all patients, especially the frail elderly, how to discuss specific goals of care and hopes for the future, and finally, how to organize the medical care to achieve specific goals. We believe these 4 steps are critical to good decision-making for aging seniors and those entering the final phase of life. Whether you're a patient, a medical professional, or a healthcare representative, we hope this website will help you explore the ways in which we can improve the care each of us receives during our senior years. We also welcome your support and contributions to this important effort. Thank you.
And now I would like to turn the webinar over to Loretta.
Good morning, everyone. We will continue what Dr. Burley spoke about with an overview of the data. New Jersey lags behind the national average of hospital service in the last days of life by 30 days. That is significant. All states receive hospice services earlier than New Jersey does. The proportions of deaths served by hospice is about the same, a little better than the national average. The end-of-life hospitalization cost in the last 6 months of life, New Jersey is almost $6,000 more than any other state or territory in the United States. And New Jersey avails itself of 11.3 physicians than other states who have an average of 8.3 physicians. So you can see where the cost adds up. The care is not especially satisfying to the patients and residents in the end of life. So the Interact quality program is designed to help us improve vastly those numbers. I will be speaking briefly about the Interact Advanced Care Planning tool. The Advanced Care Planning tracking tool is for licensed social workers, nurses, primary care clinicians, advanced practice nurses, to document and track when advanced care planning discussions occurs and refers to more detailed information about the discussion. With the advent of use of the post form in New Jersey mandated, we must be cognizant that we have to have this conversation with residents and family members upon admission. Janet will go into that in a bit. The Advanced Care Planning Communication Guide helps the staff on how to communicate with residents and family members for appropriate use of palliative or comfort care or hospice care. This is a very sensitive conversation and often an emotional one, and Interact does an excellent job of giving you guidance on how to start the conversation and how to identify and talk to different points. Identify residents appropriate for hospice or comfort care. It lists the criteria for residents who may be appropriate for hospice or palliative care or comfort care orders. It is always good, in addition to using the resource guide, to speak to hospice personnel. They know best when a resident qualifies. for hospice or palliative care. And in your relationships with your hospice agencies, you should be talking about palliative care and how they can get that started as a pathway that leads to hospice care. The earlier you start, the more comfort the resident will receive in the last days of life. The Comfort Care Order Set gives guidance on examples of orders that may be appropriate for residents who choose not to use hospice. It's a suggestion, it's a guidance. Of course, your primary care physician will make the final orders, but it gives the staff some guidance on how to do that. We will discuss now the Advanced Care Planning Tracking Form. So if you have the form in front of you, you'll see that it is a 2-page form. And if you don't have it in front of you, you can easily access it on interact2.net, which is throughout the presentation. It asks for this opportunity to fill out this form and provide the staff the opportunity to start the conversation with patients and families to discuss advanced care planning. And what it is a documentation that you did start. You are going to have the conversation about the whole anyway. This will direct you to do that as part of the advanced care planning. This is your documentation that, yes, we started the conversation. No, the resident did not want to discuss it at this time. And then it gives you guidance on when to reapproach the resident, when to talk about it, and how to complete the form. And it simply asks for the resident's name, when you started the conversation, who was the staff member who started the conversation. And then on the second page, it is used for review. You review the conversation or start it again upon readmission to your facility, your community. After a resident has gone out and come back, maybe with a new diagnosis, maybe with a concurrent chronic disease that really needs you to start the conversation. Keep in mind that the ideal way is if the physician or advanced practice nurse or physician's assistant starts the conversation, describes and talks to the resident about the disease progress and what they can expect and what do they want. That's the ideal way. Then the staff at the facility or community can then continue that conversation because care needs change. People's desires change. So it's good to have this on a course of where you will review it maybe with the MDS, maybe with your assessment in assisted living, bring up this subject and make sure that the care plan needs stay the same or if changes are made. Okay. The PULSE form stands for Practitioner Orders for Life-Sustaining Treatment, and this form serves to translate the individual's treatment goals into a set of portable medical orders that must be honored in all settings. In a healthcare facility, this form should be the first document in a clinical record, and it should be recognized as a set of medical orders implemented in the same manner as all other medical orders. In a non-institutional setting, such as a home, the form should be placed in a location that is easily accessible and likely to be seen by first responders and EMS personnel. This form is brightly colored green for visibility and recognizability and should accompany the individual whenever he or she is transferred or discharged to a facility or care setting. And the form is most appropriate for individuals with life-limiting or terminal illnesses. It's a legal document, and it speaks for the patient across the continuum of care. Okay, now we're just going to go over a few of the frequently asked questions for providers, which you can also easily access by going to the link at the bottom of this slide. Is the PULSE form mandated by law? Filling out this form is entirely voluntary. However, New Jersey law requires that medical orders contained in the PULSE be followed by healthcare professionals. and it provides immunity from civil or criminal liability to those who comply in good faith with the patient's pulse. Who should have a pulse form? Well, it's designed for seriously ill patients or those who are medically frail with limited life expectancy, regardless of their age. All right, so now if someone has a pulse form and an advance directive that conflict, which takes precedence? Well, ideally the values should be the same on both documents. But if they are different, a conversation with the patient or the surrogate should take place to determine the most current preferences as soon as possible. The pulse and the advance directives can then be updated based on these more current treatment choices. If this cannot be done and a crisis ensues, care should be provided in accordance with the most recent document, whether it be an advance directive or a pulse. The next question is, can a pulse form be completed for patients who can no longer communicate their wishes? Absolutely. A physician or an advanced practice nurse can complete the pulse form based on a legally recognized surrogate's decision-maker's understanding of what the patient's wishes are. And the surrogate can then sign the pulse form on behalf of the patient. And the last question is, are fax copies and photocopies valid? Must green paper be used? Well, fax copies and photocopies are valid. The green paper is preferred, and it should be used to distinguish the form from other forms that are in the patient's medical record. However, the form will be honored on any color paper as long as it provides the appropriate signatures. And you can go to the link at the bottom of the slide for more information. Okay, now let's take a look at the differences between the advance directive and the pulse. On the left side of your screen, you're going to see that pulse is not a medical order. The patient requires evaluation by a physician. And usually treatments cannot be limited in an emergency situation with only an advance directive. Therefore, unwanted treatments and interventions may be applied. As we continue down that column, an advance directive, it helps people to communicate treatment preferences in advance of a serious illness or an accident. It designates a proxy to make decisions should the patient lose capacity to do so. And then lastly, an advance directive is recommended for all adults with decision-making capacity. And the second column refers to the pulse information. Pulse is a medical order. It guides the care provided by all health care providers. Pulse also reflects the individual's goals of care and wishes near or around the end of life, and it transforms them into actionable orders. And lastly, the pulse form is recommended for individuals with advanced illness, frailty, or strong preferences about medical interventions in their current state of health. Let's take a look at the Interact Communication Guide. Now, this is designed to assist healthcare professionals who work in a nursing home to initiate and carry out the conversation with residents and their families about the goals of care and preferences. And as Loretta said, this is at the time of admission, at regular intervals, and when there's been a decline in health status. Communicating about advanced care planning applies to all staff, physicians, nurses, social workers, and administrators, anyone who has that conversation with the patient. And this guide is very helpful for discussion on advanced directives, durable power of attorney, living will, and pulse. This guide is good for plans when there's sudden life-threatening condition, such as a stroke or a heart attack, but it can also be used as a patient is gradually deteriorating, such as dementia, and when considering palliative or comfort care planning or enrolling in a hospice program. And here, Interact has compiled tips for starting the conversation. First, you want to set the stage. You want to understand the facts. But it's also vitally important to get the information from the caregiver or the patient to tell you the condition or prognosis in their own words, because sometimes they can be polar opposites. You want to choose a private environment. You want to have a main idea of the agenda for the meeting and who needs to be present. And always allow adequate time. You don't want to feel rushed. You don't want the family to feel rushed. 30 minutes is usually appropriate. Any longer can sometimes be overwhelming. Try to turn off your cell phone or beeper or put to vibrate to avoid any interruptions. You want to be fully present for this conversation. And sit at eye level to all the participants if possible. The goal is effective yet compassionate communication. This is a very fragile discussion sometimes. Use simple language. You want to ask the patient what they understand. You want to ask them about their goals. Most nursing home residents and their families truly are more interested in comfort than prolonging life. And this opens the door to discuss palliative or comfort care plans. Try to get a sense of the rationale for their goals. Patients may say, I'm at peace, I'm ready to go. Some people might say, I have a wedding in 3 months and I would really like to be present for my family. And so it's always good to have a little insight to where the family is coming from. And as you initiate the discussion, you briefly want to talk about CPR, artificial hydration or tube feeding, and palliative or comfort care. And you want to provide the information as appropriate, and Loretta will go into more detail shortly. And as you end the conversation, always give the family an opportunity to ask one more question. You never know what they might have thought of and just need to share before they leave. And emphasize the role that the nursing home is always there to provide comfort no matter what the goals are. And offer a follow-up meeting if it's indicated. An effective way to end the conversation is to stand up and thank them for their time. And now I'll hand it back to Loretta. As Janet alluded to, this is a very sensitive discussion. So you want to recognize that your emotions will be in play. The resident and the family member or the surrogate emotions will be in play, and you don't know what those emotions are. So you have to make sure that you're in a place where you can speak with them with compassion, empathy, and understanding before you start the conversation. I always say that a resident's journey with us, either in a nursing home, assisted living, or even home care, starts with relationship building. And a very important piece of that is trust. So this is a time when you can really gain the trust of your family member and your resident or patient. Interact does a great job of giving you a guide to hold the conversation and some communication tips. So I'm briefly going to go over this, but understand that this is just an overview, and you really should access interact2.net to get and read about what they suggest. It will really, really be helpful. So in having the discussion, in the first part being establishing trust, you want to talk to the residents and have them talk to you. Actually, it's about listening at this point. And some of the ways you can start the conversation is, tell me what you understand about your illness. Or how can I get to know you better? Let's talk about how you feel about your life in the nursing home. Recognize family and resident concerns, but do not put down other healthcare providers. I understand that you don't feel heard by other doctors and nurses. I'd like to make sure that you have an opportunity to voice all your concerns. Acknowledge mistakes. Residents usually when they have a chronic diagnosis or what they consider bad news, they're angry. And anything that gets in the way of them having their emotions and their feelings expressed makes them angrier. So if they say that they're angry about something that happened, validate that. apologize. Be humble. You are absolutely right. 4 days was too long to wait for that test or procedure. So we all make mistakes, and you want to be honest about that. Be humble. I really appreciate what you have shared with me about the medication you prescribe. It is clear that it's not the right medication for you. Demonstrate at all times respect. You can do this by saying, I'm so impressed by how involved you have been with your relatives throughout this illness. I can tell how much you love them. That will calm a very upset, anxious daughter or son by knowing that you understand their relationship and how important this person is to them. Do not force decisions. You're talking about end of life. You're talking about decisions that are important. You can validate that by saying, we've just had a very difficult discussion, and you and your family have a lot to think about. Let's schedule another and see how you feel about things then. Always, always attend to the emotions. Is talking about these issues difficult for you? Making these decisions is not easy. I validate that they have that feeling. It could be anger, it could be sadness, it could be grieving, it could be depression. Identify what? I bet it's hard to imagine life without your mom. I can see how close you are to him or her. Legitimize feelings. It's quite common for someone in your situation to have a hard time making these decisions. It can feel like an enormous responsibility. Explore their feelings. You just told me you feel scared. Can you tell me more about what scares you the most? And always, always offer support. No matter what the road holds ahead, I'm going to be there for you. Always communicate hope. Hope for the best, but prepare for the worst. And you can say this to them. Have you thought about what might happen if things don't go as you wish? Sometimes having a plan to prepare for the worst makes it easier to focus on what you hope for the most. Reframe the hope. I know you hope your illness will improve. Are there any other goals you want to focus on? Focus on the positive. Some treatments are really not going to help and may make you feel worse or uncomfortable. But there are a lot of things we can do to help you. Let's focus on those. Helpful language for discussing end-of-life care. This is also in the guide that you can find on internet. Identify other decision makers. Is there anybody you rely on to help you make important decisions? Define the goals of care for that person as that person sees them. What do you hope for most over the next few months? That could be, as Dr. Burley alluded to, a simple event. I want to be able to attend my grandson's bar mitzvah. Reframe those goals. I wish we could guarantee you will be alive for your grandson's bar mitzvah, but unfortunately we can't guarantee that. Perhaps we can work on a letter to read on that day so people will know. That's important that that person understands that even if she can't be there, she or he can't be there physically, that she or he will be remembered by the family. Identify needs for care. What types of treatments do you think will help you the most? And they may say, I just want comfort. I don't want to be in pain. I want to be able to talk to my family. Summarize and link goals with care needs. A response could be, I think I understand that your main goals are to be comfortable and alert enough to spend time with your family. We have several ways we can help you. Introduce palliative or comfort care and or hospice. Especially in assisted living, if the resident fears that they're going to have to be transferred to a higher level of care, you can always reassure them that one way that will help them stay where they live is to have extra services like palliative care or hospice services. Talk to your hospice agencies about a palliative care program that can lead that resident into hospice care. And the same in the nursing home. You want to keep your resident with you. They want to stay. This is a way that you can do that by getting extra help and the family extra help. Both services are a great help to the family at this time. as well as the resident. Acknowledge response. You seem surprised to learn how sick you are. And there again is another opportunity to have a discussion of what their understanding of their illness is. And the family should hear that so that they have an understanding of the resident or patient's condition. Empathize. I can imagine how hard this is for all of you to talk about. You care about each other so much. That means a lot to a family to be recognized that they are doing the best that they can and be with their mom or dad at this time. Explore their concerns. Tell me what is upsetting you the most. It could be something you didn't even think about, but for them it is upsetting. Explain comfort care or hospice goals. Comfort or hospice care does not help people die sooner. It helps people die naturally. It's very important for the resident and family members to understand that, as well as your staff. Let them know that this is something that will help the resident and not help them die faster. Reassure. The goal of comfort and hospice care is to improve your quality of life as much as possible for whatever time you have left. It can also help you attain your goal, whatever that might be. Reinforce commitment to care. In other words, you may say, why don't you think this over? I think comfort or hospice care is the best choice for you right now, but the decision is yours. You know we will continue to care for you whatever you decide. Abandonment is a fear when people think you're turning over the care of your loving staff, who they have a relationship to a new set of people in hospice or palliative care. You can reassure them that you're not abandoning them. They may say, don't give up on me, and a proper reply would be, what worries you the most? Why do you fear? What do you fear? And when they express a fear, what are you most afraid of? It's important to get to really, what do they mean? What are they afraid of? They may not know themselves until they start talking about it. Anxiety. I don't want to leave my family. You could say, well, what does your doctor say about your condition? Get them to understand what their condition is and what the outcome of that may be. They may have a feeling of depression, and they could be scared of dying. This is very common. People, older people will tell you, I'm afraid to die. And then your response could be, what is most frightening to you? Incomplete understanding. I do not really understand how sick I am. Again, another opportunity for you to discuss their illness with them and find out what are your most important goals. Wanting reassurance the best medical care has been given. And that's important because they don't want you to think because they're old, there's not much you can do for them. Again, to reiterate, what is your understanding of your condition? And then validate what treatment has been done and what they can expect. Wanting reassurance that all possible life-prolonging treatment is given. This is for someone who has difficulty making a decision. Don't leave any stone unturned. What have others told you about what is going on with your illness? It's important to always understand where they think they are in their disease or their condition. An important part is spirituality. This generation has a strong basis in faith. So if they are telling you they will leave their faith in God's hands and God will take care of it, your appropriate response would be to ask them, what brings you comfort? Prayer, hymns, clergy, a visit by clergy, talking with other people who have your beliefs, the Bible. Find out that's important. And if you can possibly provide clergy visits, if it's important to the resident, do it. Differing perceptions. The resident may say, I cannot bear the thought of leaving my children, wife, husband. Your response could be, how is your family handling this? And residents may ask you, as they have me, how do I tell them? How do I talk to them about this if the family member isn't present? and you can find out what they want to say. Ask them what's important to you to let them know. And you can help them with that. The children or dependent, sometimes there is anger if the family resident has not had a close relationship with the family or feel angry that they are not visiting because they live on the West Coast or whatever. They might respond, my family is only after my money. And then you can get the conversation going about, well, have you made plans for your children or other dependents? So it's important to verbalize and validate what they're feeling and try to get them to talk about it.
Thank you, Loretta. Now, we would like to share a resource created by the Atlantic Health System. Dr. Karen Knops developed an online video repository of more than 200 questions aimed at demystifying palliative care. Dr. Knops is the medical director of the palliative care program at Morristown Medical Center and assistant medical director for Atlantic Hospice. Bear with us while we bring up the audio. It should start playing soon, we hope.
So the root of the word palliative means to cloak or to shield. So in medical care, palliative care is care that's directed at reducing and preventing the suffering that can be caused by medical illnesses. Treatments that reduce symptoms of illness and improve quality of life are palliative. So these treatments don't necessarily cure an underlying disease, but they can reduce the suffering that a disease causes in someone's daily life. Because an illness can also have a negative impact on a patient's loved ones, the focus of palliative care also includes the social, cultural, and emotional aspects of care for the patient and their family. Part of reducing the fear and confusion of illness is to promote clear communication about what to expect during the course of an illness. So palliative care promotes better transitions between care settings and also helps the patient and their loved ones navigate the healthcare system, since the healthcare system itself can sometimes be a source of suffering.
The Atlantic Health Video Answers website has really provided a place for family members, especially if they're dispersed around the country, to view identical information. There's over 100 questions and answers that are really valuable to family members and a great resource for all of us. Now, let's take a look at identified patients that are appropriate for hospice or palliative care. Most of us are familiar with the cancer diagnosis being referred to hospice, but there are many others that are appropriate. Congestive heart failure and COPD are two that often see repeated hospitalizations, and these exacerbations may require a different conversation. Too often, patients think that the hospital will make them feel better when the best that can be done is to stabilize the crisis, and the cycle repeats itself. Dementia has a slower decline, and that warrants referrals when the patient can no longer walk or has very limited use of words. Total dependence for ADLs and aspiration can also become a problem. AIDS and ALS patients can benefit from consultations as well. And as a hospice nurse, I have had many kidney and liver disease patients, and we have been able to manage their symptoms and improve the patient's quality of life. Excuse me. Next slide. So there's some other triggers that might make you think of a hospice referral. Patient that has frequent emergency room visits for hospitalizations over the last 6 months. Sudden or major decline in functional status with no identifiable reversible causes. Or if there's a primary diagnosis of metastatic cancer with chronic pain and they're not on chemotherapy.
the patient that's semi-comatose or in a comatose state, patient that's unable to take oral medication, and the patient that is no longer able to eat. So let's take a look at comfort care interventions that are available for you on the Interact website, and it's under the Advanced Care Planning section. Some nursing home residents and their families are reluctant to enroll in hospice, but they would really like a comfort care plan. And the examples of comfort care orders below are available for these residents who will not have a hospice set of orders. First, let's look at diet. Allow the resident to sit up as comfortable. And if food can possibly be brought in by the family, they're eating so little that food that brings comfort, even if only a spoonful, is so valuable. The activity level, you want to allow the family to stay in the room to make the patient's life as comfortable as possible. Vital signs should really be limited in frequency as allowed by policy, because the frequent monitoring and the numbers can alarm the resident and the family, because we're not expecting that they're going to be in the normal range. As far as shortness of breath or dyspnea, oxygen by nasal cannula is recommended. If you can possibly avoid a mask, as patients so often feel like they're being smothered. And again, you don't want to monitor the oxygen saturation levels because they're probably not going to be within normal range. When someone's having a little trouble breathing, a bedside fan or open window, some fresh air is usually welcomed. As far as hygiene, of course, they'll be cared for. It's recommended that a Foley catheter is avoided at all costs. And you want to allow the family to participate, use a cool cloth on the forehead, cleanse the mouth with a wet sponge stick. And as far as pain and shortness of breath, opioids are usually most effective, and it's recommended best practices to use small, frequent doses, and you want to offer them routinely. Let the patient refuse. Too often the patient will not ask for pain medication, so it's really up to us to stay on top of that. Problems with anorexia, fatigue, or depression can have beneficial effects when dexamethasone is used, but not to be given too late in the day or it may disrupt sleep. Nausea can be a problem. You want to look at what might be causing it. Maybe there's a smell that's upsetting the patient. Talk about it a little and let the doctor know a medication may be needed. Anxiety, there's medications for that. But always take time to sit with the patient and try to explore why they're feeling anxious. There's medications for sleep. As far as skin care, you want to keep the skin moist. You want to reposition the patient for comfort. You don't want to allow any opportunity for skin breakdown. And toward the end of life, there's sometimes congestion. You want to keep the back of the throat dry by turning the head to the side. You want to reposition the patient. You absolutely want to make sure that IV fluids or tube feedings are discontinued. A scopolamine patch and atropine drops can be an easy form of medication to decrease congestion. And you want to avoid deep suctioning. It doesn't do any benefit to the patient, and it's very upsetting for the family. And again, you want to allow the family and encourage them to keep the mouth moist with the sponge sticks. Comforting, counseling, and safety. You want to sit with the patient. Just being present can be therapeutic. Reposition them. Avoid loud noises. Turn the TV off or turn it down. Use soft music. Some patients may find a CD of hymns to be very comforting. Avoid the use of restraints, bed rails, or alarms. And that's all I'm going to say about that. Offer spiritual support, and again, any type of clergy or familiar prayers are comforting. Okay. Now, let's look at deciding to go to the hospital.
And the Interact program wants to help you to educate your family members, and this information is on the website, and it's in handout form for the family. So benefits of the hospital. Well, if the symptoms are that severe and cannot be controlled, there is more services available in the hospital, lab tests, x-rays. You have the specialists that are there, and you have availability of surgery or procedures if needed, and, of course, the ICU for people that are in critical distress. Now, for the risks of hospital care, the nursing home resident is prone to many complications in a hospital. And these include new or worsening confusion, more time spent in bed. It can increase the risk of blood clots, pressure ulcers, and muscle weakness. They're getting less sleep due to the tests and the monitoring of vital signs. They're at increased risk for falls due to wrist injuries. New infections. Serious, often fatal hospital-acquired infections that can happen frequently due to a compromised immune system. And then there's always the depression that comes with being in an unfamiliar environment, missing familiar faces, and fear. But we want to look at what we can do. We can be proactive as family members. We can participate in care planning. We can be aware of the risks and benefits of a hospitalization versus treatment in the nursing home when a new symptom or condition is recognized. We can have our advanced directives in place, and we can understand the resources that are available in nursing homes. For example, do they have oxygen? How quickly can they do lab tests? Do they have intravenous medications? And understand the financial and other issues such as bed hold policies. We want to know about the treatment in the hospital versus the nursing home, and make yourself an educated consumer. And now I'll turn it back to Loretta.
Much has been said about recently, and the Atlantic City Press ran an article, Performing CPR on the Elderly is rarely the right call. And this is part of the education process that you can have with the resident and especially the family member. You want them to understand that at this advanced age with chronic debilitating disease, that it's rarely, cardiac resuscitation is rarely successful. So looking at the study that was just done in the New Old Age blog site of the New York Times, where they had 250 people participate in this research. They found that 40 to 50-year-olds had a 10% chance of survival rate. We're talking about 40-year-old people. 60-year-olds, that decreased to 8.1%. And again, at 70 years old, it declined to 7.1%. And at 80 years old, it took a gigantic drop to 3.3%. There are no statistics available for 90 years and older, or beyond old, what the success rate is successfully resuscitating a person of this age. We want to keep these in mind. And again, as Jen said, go onto the internet to net. There is a education handout for the family and the resident regarding cardiopulmonary resuscitation as well as tube feeding. So some of the educational points that you want to point out to the family member and the resident is that CPR alone is unlikely to restart the heart. The goal of CPR is to restore partial flow of oxygenated blood and to delay tissue death. It preserves the body for defibrillation. And again, in New Jersey, it's mandated that we all have AEDs, and we are compelled to use them if there is no DNR order. It's important to point this out that we don't have a choice unless we discuss this advance, the family and resident made a decision, and there is a signed DNR order. And if the DNR order is on the post, it is effective.
it's a valid order. Regardless of where CPR is started, patient will be transferred to the hospital for further treatment, possibly including intubation. And this is important to point out, that if by some miracle the heart does restart, you are going to be hooked up to life support. And then with that comes the decision for the family, which makes it much more harder to make. CPR is a choice. It's not a mandate. They do not have to have it. They can choose to do not resuscitate, and that means that CPR, no CPR will be done when the heart stops beating. Tube feeding for residents and families. This is a very important decision to have early on, especially with those residents, family members, surrogates, durable power of attorney, about end-of-life tube feeding. The main reason that residents without die is because they no longer eat and they do not metabolize their food. And the question of tube feeding always comes up. And it's a very hard decision for a family member to make to withhold that unless they're educated and know that this is the outcome of Alzheimer's disease, of dementia disease, or other diseases that cause dysphagia and being unable to take nourishment. So let's go over some points that you can discuss with them. And again, a handout is available for the family and the resident. Certain health problems cause the loss of physical and mental ability, such as no longer being able to eat. Staff can feed patients and unable to eat, but the patient may not get all of the food and fluids needed. There's no such thing as force feeding. You cannot hold a person's mouth open and pour food or liquids into it, and the family has to understand that. If not, tube feeding may be an option. Tube feeding can be permanent or temporary if the patient regains the ability to eat. Tube feeding is a choice. The risks of tube feeding could be that short-term nasogastric tube is put down through the nose. It's very uncomfortable and and only used for the short term, 2 weeks at the most. Long-term requires surgery through the stomach. There are complications due to surgery. Any surgery, the surgery comes with risk, and especially to an elder, frail resident with multiple chronic disease. Area around the tube can be irritated, painful, or infected. And if a resident has dementia, it's very hard to keep them from touching or pulling out the tube, which just means more and more visits to the hospital. It may become blocked or come out. It does not prolong life. It does not prevent pneumonia. It may cause pneumonia. It does not necessarily provide nutrition for wound healing. And the decreased mobility may exacerbate wounds or cause wounds. So this discussion should be with anyone who has the possibility of dysphagia, stroke, dementia, whatever, should take place early on so that the family has clear in its mind what their decisions, what the resident's decisions or wishes are.
Thank you, Loretta. Before we continue, we would like to get input from our audience with a polling question. Operator, could you please bring up our polling question?
Ladies and gentlemen, one moment while I pull up the question.
Thank you. You will have 30 seconds to respond to this question, and the question is, as a healthcare provider, do you have an advance directive? Please select your answer. Operator, could you please bring up the results of the polling question? Thank you. Well, it looks like we have about 32 out of 84, so about 38% with an advance directive, so we certainly applaud that, while we have about 20% indicating that they do not have an advance directive. So we'll go back to the challenge and say we do encourage you to have the conversation both personally and professionally. With that, I will turn the conversation now over to Janet, who will share some information about the National Healthcare Decisions Day.
Thank you. I want to just share a story from the Atlantic and Cape May County. Last year in 2012, the Atlantic and Cape May County healthcare providers organized National Healthcare Decisions Day. They were determined to get to as many community members as they could. They went to the mall, the library, and senior housing, as well as their own facility residents and their staff. They shared information. They had conversations. They provided advance directives. It was a tremendous outreach. Then in November, they decided to take off on Thanksgiving, since families come together, and they presented Let's Talk Turkey, which provided a month-long series of programs on advance directive education for their community. And they were so creative. Turkeys were raffled off. Turkey dinners were offered with speakers that talked about advanced care planning, and it was just a great energy, and a lot of information was shared. This year, the Atlantic and Cape May County Initiative will focus on their own staff, advanced care planning, as well as education to engage patients. Okay, let's go to the next slide. What is National Healthcare Decisions Day? Well, the slide's pretty self-explanatory. The reasons that it should be done teaches you, they have a lot of tools on this site that can help you to get the conversation started. But as you look at this slide, let's think about this. If we as healthcare providers do not document our own healthcare wishes, how do we educate our patients to do so? Next slide. So why does advanced care planning matter? Well, most importantly, it takes the burden from your family. Too many times in my nursing practice, I've sat with a distraught family member or family members that were at odds about what to do for their parents. They all had good intentions, but nobody really knew what mom or dad wanted. So have the conversation before you're unable to speak for yourself or you experience a sudden illness or accident. It really is a gift to your family if you give them your plans in advance. And I return to Dinah.
Thank you, Janet. Let's listen to a caregiver story. Sherry is the primary caregiver for her 77-year-old mother who has multiple health issues, including a rare autoimmune disorder. Several months ago, her mother was hospitalized. She had lost 50 pounds and was failing rapidly. At that point, Sherry's mom asked to simply go home and enjoy what time she had left with her family. Let's listen to Sherry's story.
I consulted with a physician of mine who helped me through previous situations, and we talked about hospice. And he asked me to consult with a physician friend of his who was a palliative care doctor. And he also did hospice at the time that we did that. We met with this doctor, and everything changed. We had one doctor that worked tirelessly to look at her entire medical history, to oversee her care from all of the care that was given by the multiple physicians, any hospitalizations she had, her medications. He looked for problematic situations and worked at resolving them. He added in multiple testing that could resolve some of the issues that she had and treated them. And he advocates for, from what we can tell, for the most part, entirely for the well-being and peace of mind of the patient and the quality of life. He supports the family and the patient, and also supports the physicians and helps cultivate a sense of camaraderie and working together through the challenge of getting this patient the best quality of life. We've had multiple support staff coming to the house helping. It's been one of the biggest challenges to make sure that medications are administered properly and care is given in a timely fashion. Too much outside care has been problematic for her because it creates anxiety. But overall, we have less problems with pharmaceutical mistakes. We have less problems with medication being administered. We have less problems with disputes between physicians and ourselves. And in the hospital, we have an advocate, so to speak, and life has become entirely different. Most significantly, that there's new hope now for us, that there is potentially better quality of life down the road for my mother. We're working hard at preventing hospital stays, eliminating unnecessary illnesses, and keeping her home as much as possible, and reducing the amount of medication she's on so that she can become more lucid and involved in her own life. And the support, there's no words to say how thankful we are for that, how coordinates our care.
Okay, as we move to the next slide, we just want to talk briefly about how do you start planning for care in advance. Well, first you have the conversation. Talk to your family members, talk to your parents, talk to your friends, see what they've done, and find a comfortable spot to at least start. Because you want to provide the dignity and autonomy for yourself as well as your patient, and you want to take the burden from your family members. Because decisions don't have to take place in a crisis mode. Give your family the tools that they need. Fill out some kind of advance directive. To document what decisions you would like at the end of your life and who would make those decisions. And make sure you have the conversation with them and see that they feel comfortable doing that for you. Think through and communicate your choices. We need to work together to educate ourselves and our patients. And there are several legal options, as you can see there, power of attorney, living will, Pulse, and the Internet has a variety of sites. The Interact site is the National Healthcare Decision site. A tremendous amount of information as you move forward with this. And now the next slide. Do you want to get involved? Let's promote advanced care planning. Let's coordinate a National Healthcare Decision Day at your facility. Complete an advance directive of your own and encourage others to do the same. Remember, there's no wrong decision, but there can be chaos when no decision is shared. And with that said, we want you to fill out an advance directive. Thank you, Janet. We have included resources that we use throughout this webinar, and we invite you to look at them. Next slide, please. At this time, we begin the question and answer portion of the webinar. And also, if your facility is currently using the Interact program or any of its tools, we encourage you to share your experience with today's participants. Operator, I would like to ask that we open the lines for questions, and the operator will provide instructions on how you can enter the queue.
Ladies and gentlemen, if you would like to ask a question, please press the number 1 key. Again, if you have questions at this time, please press the number 1 key on your telephone.
Thank you. We'll start with, there were a series of questions in the chat box, and we do encourage Sonia Shepard, if you can join the phone queue, that would be great. As I understand, there were various questions about ordering the Pulse form, palliative care, and who they should come from, and how would notifications to a nursing facility occur. So I'll ask our presenters to give a little bit of information about that, but I also do encourage Sonia to dial into the queue if you do have further questions.
Okay, well, this is Janet, and
as far as the PULSE form is concerned, I really would like you to, as healthcare providers, go to the site provided by the Department of Health. It has a tremendous amount of information. They have guidance for New Jersey healthcare professionals. They have end-of-life care in New Jersey hospitals, a blueprint for action, the frequently asked questions that we discussed. So you can certainly get a lot of information from that site. The primary concept behind the PULSE form is that the primary care doctor has the conversation with the patient, because it is this doctor or advanced practice nurse that is going to sign the document. So the whole idea was that if a patient was in a life-limited situation, that they would have a medical orders that would follow them wherever they go, from home to the ambulance, to the nursing home, to the hospital. These orders are legal orders signed by a medical professional. And this is what the PULSE form was trying to do, try to honor people at the end of their life and allow them the ability to have the conversation. And when you fill out a PULSE form, you can certainly fill it out, and then if 2 months later you change your mind, you can certainly speak with your doctor and make the appropriate changes. So the form does what you need it to do, and it makes your health care provider responsible to you to get that care across the continuum.
This is Loretta, and I'd just like to add to what Janet said. It is important that residents with debilitating chronic diseases, and especially Alzheimer's disease, because the trajectory is death, and other conditions that are either spontaneous but are often can be fatal. If the doctor does not start the conversation, does not start the PULSE form, the responsibility lies on the facility or the community to make sure that this happens. You can start by, in your facility, speaking with your medical director if you're not having any fortune getting this started by the doctor, or if you're fortunate enough to have a nurse practitioner. She can start the conversation, explain the disease process, and get the orders that match.
We have a question on the phone from Nancy Burnham at the Millville Center. Please go ahead.
Well, about the PULSE form itself, are you thinking that the physicians have a stack of the green forms in their office? I'm wondering, I can print them out, I can download them, I can put green paper into my printer machine, but I'm wondering if there's a source for the green form itself, and do the doctors, in your opinion, already have them in their primary care offices?
I will tell you that some do. Oncologists, hospitalists have access, and that's a real hard way for that conversation to be started when someone's in intensive care. But they do have access. Do I think that most primary care physicians have it? No. I don't even know that they know about the responsibility that they have. Our effort is to educate them all. The American Medical Directors Association is having this conversation with physicians and trying to spread the word, because it is a mandate. There's no choice here. The only choice is the residents if they choose not to have it. But that has to be documented, that you tried to have the conversation and the resident family member did not want to. So, in answer to your question, just go on the website that Janet said to see what is available. I don't know that you will be able to get copies, or you may. They may mail them to you. But whatever it is, photocopies of the form or whatever, get it started. The important message here is that it is a responsibility of all make sure that this conversation is started, that the post form for someone whose end of life is in question is near, that this form gets started. So I would not rely on the physicians, I'm sorry to say, because they're usually the last to comply, but it's up to us to nudge them and get them going. So if you're having trouble in your nursing home with the various providers that take care of your resident, go to your medical director and ask him to help you. Speak to the residents on that this has to be done. And that's only if you're getting pushback. If they comply after you reminding them, then that's fine. The best bet is if you have a nurse practitioner, they understand the holistic care of the resident, and they'll get that started.
Okay, I would just like to add that I don't know the source of the green paper or what shade of green, because I know some states actually do designate the exact paper color. The Department of Health might be able to shed some more light on that. And as far as the facilities, I do believe that facilities have to put in policies and protocols for the use of the PULSE form. So even though the PULSE form was released for use in the state, your facility will have to have a policy and procedure as to how they want to implement it for continuity across the facility.
Implementation and ongoing assessment of that, and that's what the Interact form is for, to have that discussion when you had it, that's your documentation, and then when you're reviewing, is the care plan the same, or if the resident chose not to have it at the beginning, are they ready now to talk? But each time you do that, it must be documented, and your policies and procedures must reflect that.
As a note, we will put the New Jersey State website into the chat box, and it's also included in the resources, so you can go there for further information. Operator, do we have more questions in the phone queue?
Yes, ma'am. We have a question for Maureen at DaVita Healthcare. Please go ahead.
Oh, good morning. How are you? I just had a comment that I wanted to make regarding dialysis, and the comment came up about dialysis treatments. There is a manual that was released in 1997 and then again updated in 2010 by Renal Physicians Associates. Primarily a lot of the work of Dr. Sarah Davison and Dr. Alvin Moss. It is the Renal Physicians Associates shared decision-making with the patient in the initiation and withdrawal of dialysis. And I'm thinking that in the acute setting, when patients come in either from facilities or from their homes and they have a significant, deterioration of status, sometimes related to cardiac or, cardiopulmonary reasons or, just declining renal function, patients may start acute dialysis in the hospital. And there is discussion about, discussing different possibilities for patients who initiate renal dialysis who may not necessarily be candidates, for really that chronic type of treatment. So often we have patients who are initiated in the hospital who die within a year. And so there is thinking that part of the planning for these patients can rely on the 10 adult recommendations that are given by Dr. Moss, and they're clearly outlined in the RPA manual. Some of them consider a time-limited trial of dialysis, and they also discuss something called the surprise question. Would I be surprised if this patient died within the next year? So these are things that nephrologists in the intensivist setting can consider and, really think about, do we want to start a patient on dialysis? Is that patient fully informed? Is the family fully informed? Do they want to do this? Or do they want to have a time-limited trial and also consider comfort care for their other needs? It's a great manual, and I just want to say that I'm extremely impressed by this presentation. It was absolutely magnificent. Thank you.
Wow, thanks. And thank you for your contribution. That is really one area where this conversation absolutely should take place. So we appreciate you sharing that with everyone. Thank you.
You're very welcome. Thank you.
I'm going to take a question here from the chat box. It's from Janine Rowe. And her question is there a New Jersey standardized format recommendation to import the post into your medical center's EMR, CPOE, and can you place the medical center header/logo on this order?
I'm not so sure about you being able to place your header on it. There is definitely a way to embed the post in your computerized system. So if you would like more information about that, you should get in touch with the Hospital Association of New Jersey, located in Princeton. They are the ones who their PSO, their Patient Safety Organization, actually was entrusted with the formation of the post and vetting it and validating it. So they will best be able to answer that question because that option of the green paper always comes up, which, Janet covered clearly. It can be photocopied. It does not have to be green. But I would have a discussion with them, with the Hospital Association and their Patient Safety Organization about the electronic embedding of that.
Okay, thank you. Do we have any more phone line questions?
Yes, ma'am. We have a question from Georgine Tracy at Absecon Manor. Please go ahead. Georgine Tracy, your line is now open, or the group at Absecon Manor. Did you have a question?
Our question was answered on the chat.
Okay, great. Our next question is coming from Sonia Shepard at Eagleview. Please go ahead. I'm sorry, Sonia Shepard with Eagleview. Please go ahead.
I'm with the Vita SJRMC dialysis here in Patterson. I know that they're Vita in person. My question I needed clarified was, in the chat box I alluded to the order coming from either me as the chronic outpatient dialysis unit or from the nursing home, and it was sort of answered. The reason why I'm seeking clarification is, yes, we have identified many patients here because my unit is a predominant nursing home assisted living residence. Most of my patients here are 75 and greater, a couple of them with tracheostomies in place. And I have been noting that because of repeated hospitalizations, there's no hospice at all started with them. Comfort care, nothing in that realm is started with them in the nursing home facility or the assisted living facility, and when they get into the hospital and they're referred while in the hospital, they normally expire within 3 days of that hospice referral startup. My clarification on who would then begin that conversation, I think, was somewhat answered, but if my medical director here in our IDT meetings want to reach out to a hospice program, is he the one responsible for filling out that post form, or does it still go back to the nursing home? Do we still then respond back to that facility to get that started there?
It should be started at the earliest possible time in situations such as you're talking about. It doesn't matter where it started, just that it's started by a physician or a nurse practice or a physician's assistant. They are the ones who are qualified to start that post and write the orders, because this is a script. This is a medical order that goes in the chart. I wouldn't wait, and I would try very hard to get your people on hospice or palliative care long before 3 days before death.
Right, but I mean, what I'm understanding is that they are repeat hospitalizations, and no one who has the day-to-day care of them is stepping up to get them onto comfort care measures. I see the pulse as you want a physician who knows you. And this is a voluntary agreement on behalf of the patient. So, sometimes the conversation, such as in the dialysis, it's a little more of a, elevated situation, if I'm not mistaken. And, I think the best choice is when the patient is day-to-day, someone can come in and talk to them. The main idea is that the physician or the nurse practitioner is having this conversation, but I think that if you are implementing it and the patient is on board, that these are absolutely their wishes, then I think that you might be showing them the way.
Thank you.
There was a question in the chat about the small font on the form, and again, as Janet and Loretta had noted, we do encourage you to reach out to the New Jersey Hospital Association as well as to the state website posted there. And those are all very good comments that I'm sure will be useful when people learn how the form is being used in the field. Is there another phone line question?
Yes, we have a question from Gail at Eagleview. Please go ahead.
Okay. The question I had was advanced directives only, residents only, or people, all of us, we're all autonomous. We can only make our own advanced directive. But, I'm not seeing the difference. I know it's an order. The whole thing that's post is a physician's order. But because it says, like, CPR or feeding tubes, things like that on there, it's still like an advanced directive in that sense, but somebody else can make it for you. And I really don't, like, so if I have a resident does not have an advanced directive, they have severe dementia, the doctor or the family surrogate can actually make this form now. My brain is not wrapping around that. How do we justify that?
I think I'm following you. The family, the patient should have a legal document that states who they want to speak for them, a durable power of attorney, that if I can no longer speak for myself, that, my son Jim knows that this is what I want. And so then Jim in turn can say, my mom has really gotten to the point where I really think that a pulse would be appropriate. And since he already has a legal document that states that he can sign, on the pulse you would just state that patient was unable to sign and that I am the medical power of attorney.
Yes, but I'm saying, do you know how many people actually really have these legal documents? They don't. That's my point. So are you saying if there's no power of attorney, like for medical proxy or anything like that, a post can still be put in place?
That is by the doctors or nurse practitioners. They are charged to, either talk to a family member. It's their decision.
Okay, so it can happen though. You're telling me that without it, like if there's no family, let's say I have a little homeless lady come in. She's never had any family. She doesn't have any legal documents. She already has severe dementia. If the physician decides that a pulse is appropriate, he's basically writing out this order that it's the same as an advanced directive almost in a sense, just different semantics, but it's saying all those things. But, like an advanced directive order.
Right. When doctors do that, or nurse practitioners, they definitely document the chronicity of the disease process, that the end result will be death, that the resident has whatever suffering, pain, difficulty breathing. They can make that decision. If it's ever a legal issue, then they will appeal to the court for a decision. If it comes down to there's nobody making this decision, or there is one person who is in conflict with what the resident wants, then the state gets involved with that.
I'm just reading off of the PULSE form here for the directions, and it says that the PULSE form should be signed by the person or the surrogate. So, again, I would clarify that with NJHA because they were, or Dr. Borelli, Goals of Care, very active participants in creating this form, and they could probably give you the background behind the answer. So the fact that it says should be signed by the person or the surrogate, I think that you have a very good question there, and I wouldn't feel comfortable just giving you a certain answer, but the goal is to have someone from the family representing the patient.
One other thing, will the post be replacing that, the DNR form, the one that's like all the first responders, in New Jersey, that one has real big letters at the top. That's what we use.
Yes. The DNR that we use out of hospital is the Medical Association. It doesn't hurt to have that one. But a DNR order on the post is legal.
Right, it's more comprehensive, the PULSE one.
I would replace that. If they do the post, they wouldn't have to have that other one then.
Yes.
Okay.
With that, I would actually like to move on to our polling evaluation questions. If we do have time At the end, we will address some additional questions, and if not, we will capture the questions that remain in the chat box and answer them and post them to our website after the webinar. Operator, could you please begin the polling question?
Okay, our first question is, my knowledge of this information increased based upon this presentation. Please press 1 for yes and 2 for no. Again, ladies and gentlemen, my knowledge of this information increased based on this presentation. Please press 1 for yes and 2 for no. And we'll just take a moment as the results come in. Please press 1 for yes and 2 for no. I plan to share the key tools of this intervention with others at my organization. Please press 1 for yes and 2 for no. Thank you, ladies and gentlemen. Please hold while I prepare the next question. Our next question reads, our third and final question is, overall, I was satisfied with the session. Please press 1 for yes and 2 for no. Again, the final question is, overall, I was satisfied with this session. Please press 1 for yes and 2 for no. Thank you, ladies and gentlemen. This does conclude our polling session.
Thank you. It does look like we are at the very bottom of the hour here. So I do want to thank Janet and Loretta for a great presentation, and also thank all of our participants. The webinar has been recorded and will be posted to the HQSI website along with the materials. And there were some additional questions in the chat, so we will address them and post them after the webinar. With that, I thank everybody for attending, and we look forward to seeing you at the next webinar. Thank you very much.
Ladies and gentlemen, this does conclude your conference. You may all disconnect.